Now we're going to move on to part 3 of our Staphylococcus lecture, and this is a short lecture focusing only on the Coagulase-Negative Staphylococcus species, or what's known in the clinical lab as the CNS. The habitat of the Coagulase-Negative Staphylococci is similar to that of Staphylococcus aureus, where it can be normal flora of the skin and the mucous membranes. There are approximately 33 species that include the Coagulase-Negative Staphylococci, and the common human isolates are Staphylococcus epidermidis, Staph saprophyticus, and Staph hemolyticus. Now, coagulase-negative staph tend to be less virulent than the Staphylococcus aureus. They can be commonly involved in nosocomial or hospital-based infections, usually associated with implantation of medical devices. So these indwelling devices, these foreign devices that are implanted in patients. The coagulase-negative staph tend to be ubiquitous, so they're found everywhere. They are normal flora, and the thing about CNS is they're ubiquitous organism, they're everywhere, so a lot of times you will see them in the clinical laboratory. However, it may not be a significant site. Usually CNS are contaminants, so you might get a urine specimen, and the urine specimen is commonly contaminated with a skin staphylococcus, such as Staphylococcus epidermidis. So you will see a ton of CNS, and it's your job as medical laboratory scientists to determine if this is the cause of the patient's disease, or is it just a contaminant that you need to ignore and try to find what is the real cause. So the CNS are Staphylococcus epidermidis, which causes nosocomial infections, endocarditis, and bacteremia. And the thing about bacteremia is a lot of times Staphylococcus epidermidis can grow up in a blood culture, and you really have to when we talk about blood cultures throughout the semester, there are criteria in order for you to determine if a staph epidermidis found in a blood culture is the cause of an infection, which it can be, or is it a contaminant from the person who drew the blood culture originally didn't clean the skin well enough. So for blood cultures, when you draw blood, you don't just use an ethanol pad or ethanol wipe like you would just to draw someone's blood for any other test. For blood cultures, you cleanse the skin with ethanol very well, then you cleanse the skin with iodine, and then you draw to really reduce the risk of any skin flora contaminating that specimen. Staphylococcus saprophyticus is a CNS that is commonly associated with urinary tract infections. Staphylococcus epidermidis is the most common isolate of the coagulase-negative staphylococci. Many times it's not speciated in the laboratory. Usually in the lab, CNS is called exactly that. It's CNS, and most of the time it's a contaminant, so it's not worked up in order to figure out exactly what the species is. It's just called a CNS. Its significance depends on where it's isolated and the criteria that's used. Like I mentioned in blood cultures, there are criteria that you follow so that you will know if, yes, this is the actual cause of an infection, or no, it's just a contaminant and we can ignore it and move on. Staphylococcus epidermidis is normal flora like all of the staph species of the skin and mucous membranes. It's gram-positive, so again it's got teichoic acids in its cell wall. It has a slime factor, or as a virulence factor, so it can really it's very adherent. It likes to stick to surfaces and skin and things like that. That's why it's all over us. It's usually transmitted through medical devices such as catheters, shunts, and prosthetic devices. Usually, infections associated with Staph epidermidis are nosocomial or hospital acquired. And Staphylococcus epidermidis, although it's normally a very innocuous organism, might cause infection. In severely immunosuppressed individuals, it can lead to a very severe infection. So we already said the immunocompromised, endocarditis, especially in drug abusers, bacteremia. So with bacteremia, blood cultures are commonly taken at several times during a 24-hour period, at least 2, sometimes 3 times throughout a 24-hour period. So blood cultures are always incubated also aerobically and anaerobically. If you found a Staphylococcus epidermidis in one of the draws, let's say the morning draw, in only the aerobic incubated bottle, and you never saw Staph epidermidis again in any of the other blood draws, it's likely a skin contaminant since it's normal flora of the skin, and it's probably not causing a bacteremia. However, if you isolated Staphylococcus epidermidis from every single aerobically incubated bottle that was placed in the special blood culture incubators, that would likely be indicative that this individual does in fact have a bacteremia caused by Staphylococcus epidermidis. It's more common in individuals that are severely immunocompromised, and any organism that gets into the bloodstream is a life-threatening organism. So any positive blood culture in the clinical laboratory is considered a critical result. So whenever a blood culture becomes a positive, you immediately do a gram stain on it and at least get a general idea of what is in this person's blood. Is it gram-positive cocci? Is it a gram-negative rod? And you immediately call the physician and let them know that an organism was isolated from the blood. It's a gram-positive coccus in clusters. You would do some very quick tests like a catalase test to confirm it is, yes, it's a staphylococcus, and you would then further work it up and get back to the physician with the details on the organism, exactly what species it is, what's its antimicrobial susceptibility, etc. Staphylococcus saprophyticus is another coagulase-negative staphylococcus. It is routinely isolated from the urine, and it causes between 1 to 20% of urinary tract infections in young women and also in men over the age of 50. So it tends not to be the cause of a urinary tract infection in individuals, in middle-aged individuals. So it specifically targets young women and men over 50. The epidemiology of Staph saprophyticus, like all the staph, again, skin and mucous membranes, normal flora. It can also be found in the genitourinary tract, and it's more commonly the cause of a UTI in young sexually active females. When it's present in urine cultures, it might possibly be found in low numbers. The thing about urine cultures, though, in the clinical laboratory is they commonly are contaminated with coag-negative staph. So usually in a clinical lab, you get a urine, you streak it out. If you see a high number of coag-negative staph, it's usually not worked up. It's usually the physician or the hospital or doctor's office where it was collected will be called, and they'll be told this urine had a lot of contaminants and we need another submission, and the patient will have to come in again and be told to really be careful about their clean catch There's a specific way to collect urine where you clean the area first and try to get rid of the normal flora of the skin before you urinate into the container. So unless an individual repeatedly has a urine culture with coag-negative staph, then it might be worked up as a staph saprophyticus. The other coag-negative gram-positive cocci, there's all of the different Staphylococcus species. They are skin and mucous membrane normal flora. Rarely are they associated with any infections. Occasionally, Staphylococcus hemolyticus has been associated with wound infections, bacteremia, and endocarditis. And there are other species of staph that, in an opportunistic case, can be involved in infection, such as in a severely immunocompromised individual. Treatment, just like Staph aureus, depending on the site of infection, possibly wound drainage, if it's a skin infection, pulling the indwelling device. If it's a catheter and causing a bladder infection, you'd want to pull the catheter. Antimicrobials are, of course, and so the same treatment for all of the staph. Now we're going to move on to part 4, which is the laboratory diagnosis.